The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Welcome to LymphCast, the gathering place for physicians, healthcare experts, and special guests. We dive into the world of lymphedema, venous disease, and other related disorders, exploring their impact on your daily life. So settle in, unwind, and join us as we uncover everything you need to know about lymphedema and related conditions on our engaging show LymphCast.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Greetings and welcome to our LymphCast show. Believe it or not, episode 45 tonight. We are glad that you are with us, however you are with us. And don't forget, if you're on podcast, you can find every episode on YouTube. And if you're on YouTube, every episode is on every podcast platform under the sun, Google Podcasts, Spotify, Apple, everywhere. Just type in LymphCast and you're good to go. We also want you to check out our website early and often, and maybe check it every couple of times every week for new information. That is lymphcastnetwork.com. Everything is there about this show, including everything that I just told you, plus our email address if you have a question for one of the doctors, hello@lymphcastnetwork.com. Let's go ahead and meet the panel tonight from Arizona, Dr. Monika Gloviczki. Hello, Dr. Gloviczki. How are you?
Hello, everybody. So good to be with you again and with Catherine today. I'm looking forward to our discussion.
Absolutely. Let's go out to California and meet Dr. Emily Iker. Not meet her. She's here every week. We're just going to say hello. Hello, Dr. Iker. How are you?
Hello, everybody. And hello, Dr. Catherine from California and all the wonderful team and listeners. Welcome.
All right. Very good. The gentleman who started this show from the very beginning. He's also the founder and owner of VitaSupport MD. They make Vein Formula 1000 and Lymphatic Formula 1000. Physician and surgeon from New Jersey, Dr. John A. Chuback. Hello, Dr. Chuback. How are you, sir?
Hi, Paul. Doing well. Great to be here. Hello, wonderful team, all of my co-hosts and our wonderful guests tonight, Catherine, and welcome all of our viewers and listeners. Wonderful to have you.
It's going to be a great show. Let's go back to Dr. Emily Iker. You'll bring in our special guest tonight, and I'll let the questions begin.
Hello, everybody, and welcome, Dr. Catherine. So, Doctor is very well known in the world of lipedema. She is a PhD and founder and CEO of Lipoedema Simplified, and also Lipedema, the disease called. And we have seen her in lipedema world quite frequently, and it is a great honor to be with you today. And you can tell us a little bit about you. How did you start, Dr. Catherine? What made you to decide to go this route and open all these discussions about lipedema that is called lipedema fat disease?
Well, first of all, thank you for inviting me. It's been a journey. Hello, all of you and all of you who are listening. Lipedema, when I started, I had complications to my perimenopause, and I had ended up in a very significant post-surgical complication. And with my primary care, we tried to figure out what was going on. I was having uncontrollable swelling. We would think it's lymphedema. They did say it was lymphedema, but all of what usually works for lymphedema was not working to reduce the swelling. So it took a while, and eventually I found Dr. Foldy's work and figured out that it was lipedema. At the time, it was very little known. In fact, you were one of the only doctors in California, Dr. Iker, that had some knowledge of lipedema. And this was going back to early probably 2011, 2012 is when I first connected with.
Was it that long?
It was. Well, I remember reading. I mean, I'm a researcher. I'm a professor. by trade. So I did research when I finally had a name, which was lipedema, and I started to research. It was barren. Of course, I found Dr. Foldy's work and Botter and a couple of others in Germany and in Europe. And then Dr. Herbst and you were the only two that knew anything about any kind of lymphatic and fat disorders.
Thank you so much for telling us about that. It is incredible that even so many years later, we still don't know much about lipedema. And with your help and with this fantastic LymphCast, it is our duty to spread the word and to correct the diagnosis of lipedema and help these wonderful ladies suffering so much. I just had a patient who is very well known in California, in Hollywood, and it was amazing to see this woman crying because she was happy that she was diagnosed with lipedema and not all the other diseases that she was labeled with. Mm-hmm. And she told me that throughout her lifetime, she's 60-something years old, and she went through bulimia, anorexia. And as you know, this is a typical story with these young women. And then they get angry and sad and they eat more and so on, so on. So thank you so much for giving us the highlight about your podcast and your information. And tell us, how did you get your team?
So I'm going to jump back to like 2013 when there was very little known. There was so little known that I decided to go to Europe, and I went to Hinterzarten, where the Foldy Clinic was, and I had connected with a number of the innovators. A couple of them were plastic surgeons because they were doing the very early liposuction for lipedema. And so I traveled through Germany, and in that process, I made the documentary film, Lipedema, the disease they call fat. And I had to go because that was the only place where there was information, but I couldn't go and just sit and have a conversation because I was traveling so far. I wanted to have something of substance. So I decided to film all of the interviews. And then once I filmed all the interviews, we ended up putting together a documentary. And I talk about the documentary because we have over, I think, close to 4 million views. We put it up on Facebook a couple of years ago, and it just has taken off. And so it's such a common disorder that has been misdiagnosed and mislabeled as obesity. And while obesity is a common comorbidity to it, it's not the main cause. It's so fascinating. We're starting to uncover more and more about obesity. Oprah just had a special on just 2 nights ago on the semaglutides because they're having great success with obesity. But lipedema is not obesity, even though they can come together. And I think what you said, Dr. Iker, that many people end up with a journey through eating disorders because of the frustration. Lipedema is resistant to diet and exercise. So let me give just a little bit of history. I think it's important to understand that lipedema was first named as an entity, as a disease entity in 1940 by doctors Allen and Hines at the Mayo Clinic as part of their staff meetings. They talked about this edema and how it appears, how it lasts, how it's resistant to any kind of intervention. And that was it. There was a paper written in the 50s. And when I started to do the research and try and figure it out, as Dr. Iker said, even to this day, there's little known, but there's much more now than there has been. And so it was 75 years. And I think the thing that moved the needle, if you will, around lipedema was a global grassroots movement. There were women in Australia and the UK, throughout Europe and Germany, and really throughout the world. And there were those of us. And so when you say the team, there was a grassroots collaboration across the world with women asking for answers. The documentary was one part of it, but there were other parts of it. The women in the UK, led by Suzanne Evans and Sherry Fetzer, with an organization called Lipoedema UK, began a survey where they surveyed women in the UK, asking about their symptoms, about their progression, about their mental, physiological, emotional lives, the quality of how they were living, their access to healthcare. So, and they wrote articles about it. So it's as if in all of our different ways, we moved awareness as best as we could. And that's what we did here in the U.S. In the U.S., I started, and I was very lucky. I had Dr. Mark Smith. He's now at Northwell Health, and he's the executive director of the Friedman Center there. And he is he's a plastic surgeon, but he runs their oncology plastic surgery for breast cancer. And the reason he got involved was because, as you all know, lymphedema is an often comorbidity of breast cancer. So he was looking for answers around lymphedema. And he also had patients who had lipedema. So together we formed the Lipedema Project, which was to bring awareness and to begin an educational process.
Well, I have a question because of course, you are talking about how difficult it is to diagnose all the road that you went through to finally get the word lipedema as cause of your trouble. So, how you can recognize it? Is that only by elimination of all other cause, or do you have some advice for our listener? What would bring the lipedema diagnosis easier for mainly women, because these are practically the all women?
Yes, pretty much. So some of what we know is that it is somehow hormonally triggered. That because it seems that. So here are some of the ways you can recognize lipedema. It seems like it initiates or exacerbates at times of hormonal disturbance. And for women, it's puberty, pregnancy, perimenopause, gynecological surgery, or usually any kind of surgery can trigger it. High levels of stress can trigger someone who has underlying lipedema. So there's this hormonal component to it, but there's also a hereditary component. So it seems like not 100%, but a significant number have inherited lipedema from their mothers, but fathers can also be carriers. So those components. The diagnosis itself is a clinical diagnosis based on history and on symptomology. So some of how you can recognize lipedema is that it is a distribution of fat that is out of balance. So typically, the upper body, especially the torso, will be what we would call normal sized or close to normal size. And the lower body will be much larger. It tends to center in the hips and the thighs and the legs, but also the upper arms. And so you get a very classic disproportion, if you will. And the other part is they call it the painful fat disease because there is pain. Most women who have lipedema will report some kind of pain. Now, that can be ongoing pain or it can be incidental pain. So you're sitting on your couch and your grandkid comes up and jumps on your lap and you feel like shards of glass are going through your legs. So pressure can induce that kind of pain, or it can be a subtle kind of burning sensation and other forms. Women report all kinds of different pain that comes along with it. And the issue, or one of the issues, is that it's progressive. Doesn't go away. You know, you sometimes think to yourself, well, it'll get better, but it doesn't. It just continues to get worse. Yeah.
I think that is why it is called a progressive disease.
Mm-hmm.
Right. And the pain, we know that there is so much tension, pressure in subcutaneous tissue.
Mm-hmm.
And another sign is, especially when I examine the patients, the tissue consistency. When you grab someone, it's so nice and soft and squishy and velvety, unlike the normal of the same age group and so on. And even though the older literature pointed out that it starts in 30s, in women in 30s, I am now really concerned and piling data on children with lipedema.
Mm-hmm.
And when the patients are coming for diagnostic assessment, I always ask them to bring children, their daughters.
Mm-hmm.
And with ultrasound studies, I can detect the differences in the ultrasound findings in mother and or a daughter. And as you pointed out, Dr. Catherine, yes, it is genetic component is so strong. And the recent study, I think it was the Italian study, pointed out 81 plus percent of the study is genetic origin. And I am also, during the consultation, asking about family background. And I would say it's even more than 80%.
Mm-hmm.
And it can be both maternal, predominantly maternal side, but paternal side, they may be carriers.
Mm-hmm.
And when the father, who is the carrier, has daughters, the chances are the daughters are going to then end up with lipedema. And another component is hypermobility. And because I used to do gymnastics way back when, I am also concerned about looking at these young girls who are gymnasts with a high probability of high flexibility.
Mm-hmm.
And you can detect that in lower extremities where there is a different subtle shape of a lower extremity and a discrepancy. And you can see that in childhood too.
Mm-hmm. There are some other comorbidities along with hypermobility. Hashimoto's and thyroid and hypothyroid tend to be a comorbidity to
and Ehlers-Danlos syndrome.
Yeah. So, you know.
What about lymphedema associated?
Yeah. Yes. So typically, and I just say typically because what we've found is that no one is typical, that everyone is so unique based on history, based on their lifestyle. But anyway, commonly, if left without intervention, the lipedema fat will continue to proliferate. And as the fat proliferates, of course, it's pressing on the other vessels. And the other vessels are part of the lymphatic system. So there ends up being fibrosis. Fibrosis develops. It's one of the things to be aware of in terms of how lipedema progresses. And as that happens, one of the things that we haven't mentioned, and I think it's important to mention it, is when you palpate lipedema, if you palpate, you can feel what like little pea size, like beans in a bag, like beanie babies. You can feel the fat has a structure to it. And the reason why is that there's scar tissue, and the scar tissue is the fibrosis, which is often a result of the inflammation that comes along with it, leads to lymphedema. So there, in the advanced stages, we talk about it as lipolymphedema. In the advanced stages, there's an increase in volume, and that increase in volume is exacerbated by the lymphatic system. So there's been a conversation ongoingly within those of interest who are doing research in this area as to whether it's a fat disorder, a metabolic disorder, a lymphatic disorder, and it's really a complex multifactorial disorder, which makes it harder to track, to diagnose, to understand, and to treat.
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
Do you think that knowing that component of lymphedema that develops in the process of the disease, is it reasonable to have the compression therapy associated to the treatment?
What we do, one of the things that we do at Lipedema Simplified is we do an educational and self-management course so that we work with those who are interested in developing protocols for themselves. And so some of the protocols that we recommend are compression therapy, manual lymphatic drainage, skin care, things like dry brushing. So the things that move the lymphatic system, which will, in some cases, prevent the progression. We often tell women that you might not be able to reverse it, but you can stop it from getting worse. It's a lot of work.
It is very intense.
Nutrition as a part of the whole protocol. What is? I know Dr. Iker is a co-author of the Lymphedema and Lipedema guide for nutrition. Maybe, yes. Emily, you should talk a little bit about it.
What we've found is that low carbohydrates are inflammatory for, maybe not for everybody, but certainly for most people. That most of the women that we work with, we find that carbohydrates are inflammatory. So when we're talking about carbohydrates, as we all know, our food system has become quite Frankenstein. We're miles and miles away from, naturally grown agricultural system that is healthy. And so that Frankenstein system has created even more complications. So the carbohydrates, even some of the complex carbohydrates can be inflammatory and can cause increasing pain for those with lipedema. So we recommend, and so I met, one of the things, Dr. Iker, you asked about the team. I've worked with Leslyn Keith over the past, it's almost 10 years. We met at NIH. She was doing some research on a ketogenic way of eating for lymphatic disorders. Her background is as a lymphedema therapist. And so she had done a study where she was looking at a small group, and they applied a ketogenic diet, and they found, I think her initial study was 12 weeks. There was significant change when they lowered their carbohydrates. So she and I met when the National Institutes of Health had their first symposium on the lymphatic system, which was September of 2015. It's amazing when just talking about it and thinking back as to, there was a progression. And so she and I connected, and when I saw the results of her study, And she was beginning to do some exploration into lipedema. At that point, lipedema was like barely whispered. We said, well, let's give it a try. And we got a group of volunteers and we tried it out with a group of women internationally. And the results were phenomenal. And so we spent several years working with our community with a ketogenic way of eating. And what we recommended was the macros. You'd have the smallest percentage of carbohydrates, 20 grams of carbohydrates. That's barely a thimbleful. So very low in carbohydrates, moderate protein, and high fat. It was the opposite of what most of us had learned. What most of us had learned is low fat, moderate protein, and high carbohydrate. So it's like almost like a 180 degree change. But it worked. We had women who had done everything under the sun, and they started to reduce the pain. That was the first thing. And then they would lose weight. We've had women lose over 200 pounds over a period of a couple of years. So it's been remarkable to see. Now, like I've said, I want to be really clear. It doesn't work for everyone. Right. It works for a lot of women, and we don't know why. Why does it work for someone and not someone else? That's what I found interesting, because Oprah, when she was talking about the semaglutides, she was saying, sometimes it works, sometimes most of the time it works, most of it we don't know why. There's so much about the human body that is a mystery. Yet when we work, I believe we can find what can work for someone. Someone can find, we do a lot of what we call N equals 1. So we tell our ladies, you have to be your own laboratory. You are in research. N is the number of subjects that you have in your research study. Well, in your research study, N equals 1, that 1 is you. And you're the one that has to understand your body, that has to understand what you react to, what you don't react to. And we've worked with thousands of women across the globe now, helping them to identify what works for them. And it's been remarkable. It's just been remarkable. But it's also in community. We have a couple of events every year. And our next event is April 12, 13, and 14. And it's called Keto and Beyond. It's really about looking at nutrition and how can you have nutrition that's nourishing, that is nurturing, that is good and not calorie restricted. Also maintains a healthy body and a lifestyle.
What do you think, because we are talking about the ketogenic diet, what do you think of this keto gummies that are multiplying now as a supplement to lose weight?
I have not I haven't been a fan of what's called exogenous ketones, and the gummies are exogenous ketones. We're doing a study. We're in the midst of doing a very small study, seeing how women react to exogenous ketones. And Siobhan Huggins, who's our research specialist at the Lipoedema Project, she just did a presentation at a citizen science conference that happened this past weekend in Las Vegas. So she reported the beginnings of what we found. I don't think there's a magic formula. I mean, the thing about the gummies is that, there's this magic bullet that they try and say, here, do this X, Y, or Z, and you'll be transformed. It's never that easy. It's just never that easy, especially with a disease entity like lipedema, like lymphedema. It's something that needs to be managed, but when you know how your body responds, you can manage it well.
Catherine, let me jump in right there because it's a subject that's near and dear to my heart, which is on this program, essentially every time we get around to that exact subject, which is the management of these diseases. And this is true for many diseases, but not all diseases. I always say appendicitis is easy to cure, and so is a bad gallbladder. This disease process, lipedema and lymphedema as well, not to confuse them as being the same, because we know that they're not, and there is some overlap perhaps. Both of those unique disease processes require a multimodality, multifactorial approach with a team of people, both clinicians and therapists. And so one of the areas that I'd like you to comment on that I think is important in both of these diseases, beyond the physical, beyond the nutritional and dietary subjects, and even surgical subjects and things that we often touch upon. Can you talk to us a little bit about the psychosocial and emotional aspects of these diseases?
So that's my area. I did my research on that area. You're looking at a very, very complex environment within which we live that has stigma attached to any kind of, I want to say fat, but it's much more than fat because we're also talking about disfigurement. Lipedema is disfiguring, so is lymphedema. If you have both equally, it can, both together can be pretty intense. So our culture, and it's not only our culture here in the US, but culturally, for the most part, there is a level of stigma, or in the healthcare system even, it's called anti-fat bias, that is not only explicit, because, there's a kind of collusion that it's one of the last discriminations that seems to be acceptable. In the literature, they talk about it from the point of view that there's controllability, that the reason why someone is fat or overweight, or in the cases of lipedema and lymphedema, that there's disfigurement as a result of size, as a result of volume. We now know it to be mostly swelling. It affects one's body. It affects one's mind, soul, and identity of being in the world. And so when you're looking at that, you're looking at a complex landscape, if you will, internal and external. And with our, just look what happened just recently with, in the UK with Kate Middleton. There was a tiny Photoshop of one of her photos, and it's blown up. And it wasn't even her body. It was the sleeve of her sweater or something like that. So there is such judgment. And the work that was done a number of years ago about the impact of media on women and women's self-image and where they fit in the world and society. Huge topic. In fact, Lisa and I are doing quite a bit on it now because we feel like it needs to be spoken to. And one of the places that it especially can affect is women in the workplace, in their career, because if you're not, if you don't fit in to the norm, if you will, or what they call the beauty standards, there's repercussion. There was a study done at Harvard on implicit bias, and they surveyed quite a number. I don't have the exact. I have it in my records in my PowerPoint, but they surveyed healthcare professionals, even healthcare professionals who worked in obesity medicine had bias towards obesity. So it's very complex. For some reason, culturally, we think it's okay to demonize fat. Again, because we blame, it's like you you wouldn't have a patient who came in and got diagnosed with cancer and then turn around to them and say, you did it to yourself. Now go away and come back when it's better. But that's what they do to people who come in. I was just talking to someone last week, and she had a tumor. She had a non-malignant tumor that they had diagnosed as a fatty tumor and told her to lose weight and come back. It's like things like that are common. We hear that common in stories in the community.
Yeah, and I think the other important area to look at, there is this so-called, as you say, anti-fat bias and fat shaming and so forth that we hear about. And I think it's probably across genders, but certainly I think, as you point out, women are subjected to it disproportionately. And then it brings to mind something that Emily was touching on earlier when she was talking about the gymnasts and so forth. Talk about how devastating this can be for young women, adolescent women, teenage women, et cetera.
Oh, it's devastating. I mean, some of the social media reports are astounding, how the levels of eating disorders, especially the bulimia and anorexia, and how it impacts young teens. But there was a study done with young kids. I'm talking about, 4 and 5 and 6-year-olds, where they were given stick figures of thin, a little not thin, a little overweight and fat. And they were asked who they wanted to be friends with. And across the board, they didn't want to be friends with fat stick figures. It's an old study and it's stunning. And so you say to yourself, well, how does that inculcated? It's so much a part of our culture. It's so much a part of what we pick up that even a 4 or 5 or 6-year-old would know, gee, I don't want that. I don't want to be around someone who's fat. So imagine going to school and being the one who is fat. And how do you fit in? How do you maneuver? How do you find the way to be and develop and become the human that you are meant to be? So when you talk about psychosocial issues, there's a complexity, but the other side of it, which is remarkable, is that I found, I'll actually share a story. Dr. Matthew Carmody was my primary care. He's retired now, and he's actually, he does some work with us now. He was my primary care for over 30 years. And when we were exploring this, he really partnered with me in understanding and trying to figure this all out. So I referred numerous patients to him, and they would say, his staff would say, that the lipedema patients were the best population. They loved it when the lipedema patients would come in because they were so nice and they were so knowledgeable. And so one of the things that Dr. Carmody and I have noticed and observed is that those with lipedema, the way he said it to me is, I found no population that has more of a right to be upset and angry and bitter about their treatment in the healthcare system. Yet for some reason, they're the nicest patients that they had. And his staff would always comment on it. And I find that working with our community, we have a very large community globally now. Women come looking for answers, looking not only to receive support, but offer support. There's a kindness to it that has been really a blessing. And so I think that's part of it. And I want to address what you said, John, because I think it's an important issue. Male versus female. There's obesity, there's both genders. It affects women in ways that it doesn't necessarily affect men. Men are valued for their productivity. men are valued for their contribution to the world, to what they do, how, the money they make, the position they have. Women are valued in our culture, mostly objectified as either sexual objects or having something related to what we call the beauty standard. And so that's why, I think that's one of the reasons. I think it's more complex, but I think that's one reason why. And so if you are living with disfigurement, you were talking about Amy Rivera. Amy has lymphedema and has dealt with it for a very long time. She became a bodybuilder and she had amazing results, as I'm sure you know, because you've had her on the show numerous times. And so, but even with that, she talks about the psychosocial impact and the disfigurement. And she is drop dead gorgeous.
Oh, definitely. Amy and Amanda Sobey as well. I don't know if you know Amanda, but they've both been incredible inspirations to us all and have done amazing things in transforming their bodies and dealing with the lymphedema that they unfortunately developed. I'm going to switch gears for a second because I have a question that Emily touched on it and you touched on it, and we use these names often in our show, but I would think that you and Emily could really bring some historical background based on your vast experience. We mentioned Dr. Foldy and Dr. Votter, and I wonder if the two of you could give us and our listeners some historical background on Dr. Foldy, Dr. Votter, and any other of the pioneers that you think may be important for us to know about and to study, and mention also their pioneering work and how much of that work seems viable or practical even today.
Well, if you want, I can jump into Dr. Foldy. I had the honor of knowing Dr. Foldy personally. Dr. Michael Foldy was originally from Hungary, and after 56 revolution, he migrated to Germany with Ethel Foldy, and they set up the lymphedema clinic in Bavaria, and his focus was to study lymphatic disorders. So they started with lymphedema treatments center, and that was probably the first large center in Europe. And later on, Dr. Ethel Foldy started to focus more on lipedema, but predominantly he was a lymphologist. He was actually one of the fathers of lymphology and a founder of the World Congress of Lymphedema in actually all over the world. And I am grateful to be a member of the World Congress of Lymphology, and my mentor was Professor Leduc. And at that time, you had to be appointed by a member from the World Congress of Lymphology to become a member. So I think it was in early 1990 when I was appointed by Professor Leduc to become a member of the World Congress of Lymphology. And Dr. Foldy and his wife Ethel Foldy did tremendous work in realms of lymphology, lymphatic disorders, and so on. And I think lipedema became a little bit known initially about 20 years ago. I think, Catherine, you can agree with me. And we didn't know where to fit lipedema because it was not true lymphedema. The lymphatic, and when we do the studies, the lymphatic anatomy, unlike in lymphatic disorders, lymphatic anatomy is there. Perhaps the lymph vessels are dilated, but maybe there are a little bit more lymph nodes present, but the anatomy is there. It is the tissue consistency, subcutaneous fatty tissue disorder that is in lipedema. And if there is progression there, and there was an article written by the French therapist where pointed out microaneurysm in lymph vessels in lower extremities distally, which would lead to onset of lymphedema. So we had a great mentor in Dr. Foldy, and then the European crowd, which was combined with Leduc and Fluke and Eliška from Prague. They did tremendous work on lymphatic disorders. But I think it is comparing two different entities, lymphatic disorders and lipid disorders, and they are so very complex. And as Dr. Catherine so already pointed out, even though I've seen so many lipedema patients, there is not one identical. Each one has a different variation in clinical presentation or symptomatology. And one interesting point is none of them respond to dietary changes. None of them respond just to exercises and so on. It's a combination. And talking about our friend Amy, she's incredible, but how much time it takes to pay attention to lipedema or lymphedema. In this busy world, one cannot spend 2-3 hours doing manual lymph drainage and pumping and exercising and so on. So it's very complex disease. And I don't know much about Vader, and Dr. Vader was, I think, the initial one who started with lymphatic disorders. And from Dr. Leduc, I know that he started with more cosmetic approach initially, and he found results by doing facial cosmetic drainage. And then from that point on, he started to focus on manual lymph drainage and teaching courses in manual lymph drainage.
So I'll add a little bit because Dr. Iker did such a good job at explaining really the core history. In the U.S., lymphedema and lipedema was not known, even lymphedema. One of the things is it's not taught in medical school. And I think Dr. Stanley Roxon, who is the chief of the lymphatic center and cardiologist at Stanford Medical Center, really has been the innovator, I believe, in getting things to happen here in the U.S. and in some ways across the world. So Dr. Roxon was getting referrals years ago with patients who had all this uncontrollable swelling because of his cardiology, because that's part of heart disease. And they didn't have heart disease, and he finally was able to identify that it was related to lymphedema. So Dr. Roxon has been a major part of raising awareness, definitely throughout all of the U.S., but even globally. He's been part of the LEARN, the Lymphatic Education and Research Network. He's their medical advisor, and he was instrumental in starting the lymphatic focus of the Gordon conferences. The Gordon conferences happen, I think, every year, maybe every other year. But the Gordon conference in lymphology just happened in Ventura, California, 2 weeks ago or something like that. And he's now a co-chair of a commission on lymphatic diseases that was put together by, I think it's NIH. I'm pretty sure it's NIH. Don't quote me. One of the big, it's either NIH or the CDC or something like that. They put together a commission for exploration on lymphatic diseases, and Dr. Roxon is the co-chair. I got a news blast about it some weeks ago. And so I think folks like that are the lifeblood, if you will, of the knowledge, the exploration, the research. Dr. Roxon's done numerous research projects. He recently came up with platelet factor 4, which is a genetic component that might be a good indicator of lymphatic disorders. So there's this research that's happening, and I believe that that is what is going to take us further. I want to add to, because I spent quite a bit of time in Hinterzarten, which is where the Foley Clinic is, I was blessed to have time doing rounds with Professor Foley for several months, and I learned so much. I'll never forget the day where she went, "Come here, come here, come here." And you could see the tiniest lymph vessel on, pulsing and right under someone's skin. And I'm like, she's going, lymph, lymph, lymph.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
It's amazing to hear that. I have to admit, I haven't seen that. So that's...
And I really found that, they pushed so much the global awareness of about the lymphatic system, because even among the very best so-called specialists in Europe, there was a resistance in the beginning to believe that there is a possibility of the efficient treatment. Mm-hmm. And because they had such a fantastic results, with the, backed up by the science that they were developing around. And it was, I visited them and I found that it was one of the eye-opening for me about, globally speaking, the lymphedema. And not lipedema this time. We're not absolutely talking. Mm-hmm. It was long ago. It was in the 90s. But what I have seen, probably it was exactly what was impressive for you two, is that very systematic approach with the good protocol, and you could see how it works simply.
We've just discovered another practitioner who is out of Manchester in the UK. His name is Raymond Perrin. He's an osteopath. So my colleagues, Kelly Bell, his wife Jen Bell, and Leslyn Keith have been doing exploration on central lymphatic dysfunction. So Kelly had a procedure that ended up blocking his thoracic duct. And as we all know, the thoracic duct is the main transport of the lymphatic system. So it was Kelly who found Dr. Perrin, and we had Dr. Perrin come to Boston recently, and he did a training program for a number of mostly CLTs. So what Dr. Perrin, in fact, he might be a great person for you guys to chat with. 35 years ago, he began to identify that the lymphatic system was in the brain as well as the rest of the body. So it sort of is mind-blowing to me that, we are a whole body, that people would think that the lymphatic system stopped at the neck, which is what common belief was up until a few years ago. Well, Dr. Perrin actually was exploring it, and he talks about it as the glymphatics. So the glymphatics in the brain, how they process and clean out the system. So the lymphatic system is, as far as I can see, given that I've been dealing with lymphedema for so long, is possibly one of the most crucial systems in the body because it's cleaning things. And so there was much that I began to understand in more depth in the time with Dr. Perrin. So we have the blood-brain barrier. So there was an assumption that the cells could not get through the blood-brain barrier. Not at all true. They can. And he explained how, and I'm not going to go through all that, just to say that what he's done and able to come up with some techniques that he's worked with people who were totally debilitated from the toxicity of the lymphatic system, bedridden, unable to walk, move from chronic fatigue and ME. Sorry, I can't say what ME is. I can't pronounce it. And so he developed this process, this procedure called the Perrin technique that's had unbelievable results in helping to detoxify using the glymphatics. So he has a exercise process for the face and the head and the neck, and then the spine. So through the central cerebral fluid. It was fascinating. This is not lipedema, but it is because, the lymphatic system is the detoxifier. All the toxins that are in your system, they end up either getting processed out through the venous system or end up trying to process out of the lymphatic system. And there's so many ways in which that process gets stymied. And while manual lymphatic drainage moves the lymphatic fluid, if it can't move, what are you doing? Where's it going to go? Like someone like Kelly, who has a blocked thoracic duct, he's not getting the transport he needs. So it's fascinating. The whole thing is fascinating. John, I'll have to introduce you to Dr. Perrin.
Oh, that'd be wonderful. We would love to have Dr. Perrin on the program. That's very, very exciting stuff. For our listeners who are interested in doing their own research and looking things up, ME is myalgic encephalomyelitis.
Thank you.
I can get that one out, fortunately, but it is related to chronic fatigue syndrome and can cause debilitating fatigue and so forth. So a very interesting subject to look at and talk about. I think we're coming very near to the end of our time, but there are a couple of questions that came to mind in speaking with Catherine tonight, and she's just such a wealth of knowledge and has had such an incredible life experience looking at this subject, and obviously has traveled around the world and spent time with incredible and influential and essential people in this field. A couple of I guess the first question that I have to close, which is a bit of I think would be shocking to many people. My question would be, have you found, and I don't know the answer to this, it's a legitimate question, because you mentioned eating disorders earlier, have you found any evidence or tendency of eating disorders in the lipedema population? Because I would think that at some point, patients with this problem might become so desperate to lose weight, to change their body, to change their appearance, things like bulimia and those kinds of extreme circumstances may exist.
Yes. The simple version is yes. I know of one particular case where someone was so thin, you would look at her and worry about her because her upper body was almost skin and bones, and her lower body was fat. She had lipedema. I have images of bodybuilders who are in incredibly good shape in their upper bodies, and in their lower bodies, they have the distribution of fat that is lipedemic. So it is a disorder. It is not just obesity, but obesity and the eating disorders that come along with it are part of it, which is where it becomes so confusing. Right. Because again, obesity is ascribed to be lifestyle choices. I loved hearing Oprah say that the other day on her special when she talked about, oh, there's something more than just me eating or me eating too much or obsessing about food.
Right.
It's a complex relationship. Again, in the literature, they talk about controllability, which means that the assumption is that the person can control it. Eat less, you'll weigh less. Exercise more, you'll be in better shape. It doesn't always work. It works some of the time, but not all of the time. And so, I think while education is a piece of this, try and tell someone that, because those of us in the community who know this, we have trouble believing it.
Well, I saw, to echo that point, I saw a new consultation yesterday, a woman with very classical and very extreme manifestation of lipedema yesterday, who came to see me for the first time. And I'm going to have to ask her for permission to share photographs with our viewers, because they're so dramatic from an educational point of view. There's not a human being alive on earth who can see the pictures of this woman and say that lipedema is not a disease. Mm-hmm. I mean, her, as you used the word earlier so perfectly, and unfortunately it's apropos, and we've used it before on the program, dysmorphic body habitus, her dysmorphia is so pronounced, it's so exaggerated in terms of her body, upper body versus her lower body, and the extreme lobules in the quote unquote saddlebag area, and then of course over the knees and so forth. In the lateral hips, buttocks area, the dysmorphia is so apparent to any layperson that it would be impossible to ever blame what's happening to her on her, number one, or to deny that what she has is a disease that we need to learn more about, or to deny, in my opinion, that this is a genetic disease and there is going to be a gene identified specifically for this, because she is so obviously diseased, quite frankly.
Yeah.
And I hope to be able to show those photographs soon. I'm sure she was a teacher, she's an educator, a lovely lady, and I'm sure she would be happy to do that. But it was our first meeting, so I didn't want to get into that, of course, right off the bat. But we will have that discussion, and hopefully I'll be able to share that, only for the purpose of educating our viewers, and especially in many cases our physicians. I don't have to convince our lipedema patients. But many of our physicians who are still doubtful that this is other than something, as you say, the disease they call fat. There's a lot more to this. And hopefully these discussions in this program will continue to shed light and bring awareness so that more people can get treatment. I'll ask one last question, Kat, and I just can't let you go. I know you're so heavily involved in this. Because we're bringing more and more surgeons on the show, and I'm seeing more of my surgical colleagues getting involved. What is your general feeling about surgical intervention, liposuction, and the utility of that in this disease process and the future of it?
I believe that there has to be solid conservative care in place and in a protocol before surgery, during surgery, and after surgery, like compression management, like diet and exercise and movement, like nutrition. All of the things that we support, that the surgical intervention, there's numerous evidence of the lipedema fat reappearing or coming back. Not in the first year or the second year, but sometimes 2 and 3 and 4 and 5 years, that there can be a reoccurrence. And so the more that someone is stabilized and has a protocol and a self-care structure that works at keeping the lymphatic system moving, keeping the inflammation as best as it can be diminished.
And I strongly think a psychosocial and emotional support system should be a part of that protocol.
Yes, me too. I agree. So that's what our approach is, a holistic approach, and that's how we developed it. We developed it around physical, mental, psychological, emotional, spiritual, and social aspects. That's our holistic approach. We work with our ladies on each one of those dimensions.
Well, I personally, as a physician, an allopathic physician and a surgeon, I'm very glad to hear that you included spiritual in it. I know not every physician will agree with me and think that might be hocus pocus or mumbo jumbo. I guess we're all allowed to have our own beliefs, and I think it's a valuable component of the work you're doing, quite frankly.
Mm-hmm. Yeah, thank you. Me too.
With that, Paul, can I give it back to you to say good evening to everybody?
Absolutely, sir. Another terrific show. You've been watching LymphCast, episode 45. Again, every episode is on YouTube. Every episode is in podcast land, Google Podcast, Apple Podcast, Spotify, Amazon, Audible, you name it, and we are out there. And again, visit our website early and often, maybe several times a week, lymphcastnetwork.com. Let's go ahead and thank everybody. Now, Dr. Emily Iker, before I officially thank you and the rest of the panel, can you take a moment to thank our special guest tonight?
Well, thank you, everybody. Thank you, Dr. Catherine, for wonderful discussions. And we could keep on going for another day without any stop, but we came to conclusion. So good night, everybody. And thank you for joining us. And thank you, my wonderful team.
Thank you, Dr. Catherine Sale. Thank you very much.
Thank you. Thank you all.
All right. Also out in Arizona, Dr. Monika Gloviczki. Thank you very much. Another terrific job.
Thank you. It was absolutely a great discussion and a privilege to have you with us, Catherine. And I hope that it's the only first among several sessions that we could have to discuss further the issue of lipedema.
Thank you. Thank you all.
All right, thank you. And the gentleman who started this whole thing way back when, he is also the founder and owner of Vita Support MD. They make Vein Formula 1000 and Lymphatic Formula 1000 from New Jersey, physician surgeon, Dr. John A. Chuback. Thank you, Dr. Chuback, for everything.
Thank you, Paul. You just reminded me way back when I had the idea to start this program, I pitched it to Monika and Emily, and I said, I don't know, what do you think? Do you think it's a good idea? And they both said in unison, what took you so long? And now that we've been making these programs, I wonder what took me so long. Because I know that we're educating, but I say it every single time. No one's learning more than me. Every time we have another show, my vision of these problems and the importance of these problems and the mountain that we have to climb in terms of learning more and being able to offer more treatments and more therapies and more options to our patients. We have a lot of work left to do. And so I'm glad we're doing our little piece. And I want to thank, again, as Emily likes to say, my wonderful team, because it really is a wonderful team. And we look forward to following up with some of Catherine's connections and people that she's going to introduce to us and help us to bring on the program so we just can continue to spread knowledge and light and awareness. And as I always like to say, remind our patients with these problems that there is help out there and there is hope out there. So please never give up. Keep tuning in. Send us your questions. Send us your comments, and we will certainly respond to them in the future. Thank you so much.
Well, thank you very much, everybody. And for our listeners and or viewers, we appreciate you very much. Again, check out our website, lymphcastnetwork.com. This has been your LymphCast show, episode 45. Thank you very much. We'll see you next time for episode 46. Have a great night.